The following recording is an extract from the BBS UK Medical Information Booklet and includes information about the endocrine system and diabetes in Bardet-Biedl syndrome, BBS. Information about other features of BBS, genetics, diagnosis and family planning, the specialist BBS clinics and the charity, BBS UK can be found on the BBS UK YouTube channel and on the BBS UK website. The medical information booklet can also be downloaded from the BBS UK website www.bbsuk.org.uk. The information contained within the medical information booklet has been provided and checked by the BBS Specialist Clinics team and where possible is supported by research and published articles. A full list of references can be obtained from tonia.heimers@bbsuk.org.uk. Bardet-Biedl syndrome, clinical features and presentation. Endocrine. Male reproductive system. Hypergonadism, lack of production of sex hormones, is common amongst males, affecting up to 30% of BBS patients. A small, buried penis with reduced volume testes is common. 10% have undescended testes at birth. In the majority of cases, this is due to partial failure of the hypothalamus/pituitary gland with low or inappropriately normal luteinizing hormone, LH, and follicle-stimulating hormone, FSH, with low circulating testosterone levels. In a small number of individuals, there may be primary gonadal failure. There is usually sufficient testosterone production to permit normal pubertal development. The timing of male puberty is often slightly delayed, but with normal progression and secondary sexual characteristics. Puberty is a particularly stressful time for those with BBS. Regardless of their sex and, where possible, referral to a counsellor with experience in this field can be of help. Adult male patients with hypergonadism may be prescribed testosterone replacement by an endocrinologist. This may take the form of either injections or daily gel preparations. While this may help with sexual function and libido, an important benefit is likely to be in the preservation of bone mineral density and reducing the risk of fractures. Although affected males are likely to be infertile, several have fathered children. Female reproductive system. Hypergonadism is much less frequent in women. However, structural anomalies of the female genitourinary tract are documented, including vaginal atresia, abnormally closed or absent vagina, hydrometrocolpus, collection of watery fluid in the uterus and vagina, ectopic urethra, urethra that terminates somewhere other than the bladder, hyperplasia, underdevelopment of the uterus, ovaries and fallopian tubes, and septate vagina, vagina that is divided. Women with BBS tend to have a normally timed puberty, and although there is little evidence to suggest secondary hypergonadism, polycystic ovary syndrome, PCOS, may be present in up to 20% of women with BBS. This can lead to problems with menstrual irregularity, acne, and hirsutism, excessive hair. For those patients who are considering fertility, polycystic ovary syndrome needs to be considered should there be a delay in conception. Several females with BBS have given birth successfully to healthy children. Diabetes. Diabetes mellitus is present in nearly 16% of adult patients with BBS. It rarely presents before adolescence, and in this age group occurs in those with the highest BMI scores. A higher proportion of patients may have abnormalities of glucose tolerance, and regular screening for the development of diabetes is recommended. The underlying BBS ciliopathy and high BMI scores contribute increased risk factors for diabetes mellitus. This can be controlled with combinations of diet and medicine, including insulin. Newer therapies, for example, GLP-1 analogues and DPP-IV inhibitors are also potentially useful to try and optimize glycemic control. Regular diabetes assessments are important and should be carried out at least annually. Preventable diabetic retinopathy can lead to rapid deterioration of vision already compromised by rod cone dystrophy. Alongside monitoring for complications of diabetes, it is important to control blood pressure adequately, and all patients with diabetes over the age of 40 should be on lipid-lowering therapy. Both of these measures are aimed at decreasing long-term cardiovascular risk. Up to 19% of patients may have subclinical hyperthyroidism, and it is possible that they may benefit from monitored thyroid hormone replacement. At diagnosis, assessment should include measure height and weight, calculate BMI, check hormone levels, pelvic ultrasound examination, females, fasting lipid profile including triglycerides, fasting plasma glucose, FPG, oral glucose tolerance test, fasting plasma insulin concentration, thyroid function test. Follow-up assessment should include annual measurement of height and weight, annual thyroid function test, annual fasting plasma glucose, annual screening for sleep apnea. Patients affected by any of these issues should speak to their GP for a referral to an endocrinologist and/or counsellor where appropriate. Patients of the BBS multidisciplinary clinics should speak with their endocrinologist or BBS clinical psychologist. Diabetes UK can offer information and support to those affected by diabetes. www.diabetes.org.uk 0345 123 2399. This information is meant as a guide only. If you feel concerned about anything you have heard, please seek medical advice from your GP, consultant, or a member of the BBS Clinics team. We welcome your comments and feedback. Please send to info@bbsuk.org.uk or tonia.heimers@bbsuk.org.uk.